Up next, we have a topic that demands both precision and perspective in obstetric care, which is trichorionic and dichorionic triplet pregnancies by Dr. Amarnath Bhide. He is a consultant in the fetal medicine and obstetrics at the St. George Hospital in London. He's a lead for the Day Assessment Unit and honorary reader at St. George University, London, co-director of the MFM subspecialty program, and deputy chief editor for AOGS, and member of the editorial board for 2 other journals. Over to you, sir.
Thank you very much, and very good morning to you. Thank you for the very kind words. I'm here to talk about triplet pregnancies and why we should be concerned about them. So the first question to answer is, how common are triplet pregnancies? How often do we see them? Spontaneous triplets are fairly uncommon, 1 in 7,000. So if we are working in a busy hospital, spontaneous triplets we're likely to see maybe once a year, but they are becoming more common. They're related to the number of embryos transferred after IVF. And with IVF use, we are seeing them more and more common. There's a slight reduction of increase of triplets in the UK since 1998. Since in the UK, there's a regulation that IVF doctors cannot transfer multiple embryos unless there is a good reason. So the emphasis is to practice single embryo transfers as far as possible, and in exceptional circumstances, 2 embryos are allowed. So since that regulation has come in the UK, the number of triplets have gone down, but that has resulted into increase in the number of triplets with mixed chorionicity. And that is something that we have seen when I started my professional career. Most of the triplets I used to see were trichorionic triplets because they were spontaneous. Now, a fairly large proportion of triplets I see are not trichorionic, but they are triplets of mixed chorionicity, and they've got a problem, and I will tell you as we go on. In the UK, we see approximately 200 triplets a year. So it's not a big number, but there are multiple problems, and again, we will go through them. There's an increase in the incidence in the US, and that is quite a lot, and I will show you how that has panned out in the previous years. Large majority of triplets that we see now are after fertility treatment, not necessarily IVF, but controlled ovarian hyperstimulation, we see triplets as well. So this is what has happened to triplet rates in the US. And you see the regulation is less stringent in the US, and that's why they're seeing more and more triplets in the US. As opposed to that, the triplet birth rate in the United States has remained more or less constant. And that's because of interventions that we do. So if you look at all the triplets, the commonest triplets that we used to see were these, trichorionic. So each triplet having its own placenta. Not any longer. We are seeing more and more triplets with dichorionic triamniotic. So 2 of them sharing a placenta, or dichorionic diamniotic. So 2 of them sharing the amniotic sac as well as the placenta. And these are the ones that we see, we call them triplets of mixed chorionicity. Now there are some rare ones, and I'm mentioning here just to complete the list because these are not common at all. Monochorionic triamniotic triplets, monochorionic diamniotic triplets, and monochorionic monoamniotic triplets are also seen, but they are very uncommon. So in practice, what we deal with is either triplets with a separate chorionicity each, or triplets with a mixed chorionicity. Now, why should we be worried about triplets? And we should be worried about it because of complications. Complications are early pregnancy loss, preterm birth, low birth weight, growth restriction, stillbirth, and increase in the neonatal morbidity and mortality. And as compared to singletons, twins are higher, triplets are even higher than that. And sometimes we have to deal with maternal mortality as well, because although not common in triplets, there are problems with triplets, and all these problems can compound, leading to risks to the mother's health. Now here you can see the gestational age and birth weight characteristics by way of plurality. So in triplets, you see that early preterm birth rate is seen in 66%. So 2 out of 3 triplets will deliver very preterm, and that is, we are talking about less than 34 weeks. And almost all of them will deliver preterm. 98% will deliver before 37 weeks. And that is paralleled with the birth weight. Very low birth weight is seen in, again, 1 out of 3, and almost all of them will have low birth weight. Now, this is something that tells you the comparison between twins and triplets, and that is the cerebral palsy rate. So we see the cerebral palsy rate in the dotted line shows you cerebral palsy rate of twins, and the upper line shows cerebral palsy rate of triplets. So we are talking of cerebral palsy rates of approximately 40 in 1,000 pregnancies. Now, if we break it down to gestational age-related risks, then we see that the risks of cerebral palsy is not because of being triplet, but they are because of being born early. So you see, if we match it with gestational age, the cerebral palsy rated twins and triplets, they are parallel to each other. So it's not that having triplets is a problem, it's having triplets and giving birth early because of triplets. That seems to be the problem. So that's the rate of prematurity. Again, it is compared with singletons, twins, and triplets. And you see that the mortality rates parallel each other. And these are rates of twins discharged, or fetuses discharged, or babies discharged home with no reports of major morbidity. And that's also very comparable. Again, telling us that it is not the fact that they're having triplets, but because they are being born too early. So all of them are related to prematurity. Now, what can we do about it? Can we reduce the rate of prematurity in triplets? So there's a Cochrane review on this. Cochrane review has got one problem. The Cochrane reviews are very selective in the number of studies that they will select. So the mean gestational age is significantly lower with reduction, but cerebral palsy rate is not significantly less. Why? Because if you look at the numbers, the number of infants included in the review are pathetically small, 70 to 110. So not very good, and they're not going to show you any significant differences. One cerebral palsy is seen in trichorionic non-reduced, and 2 in those who are reduced. So not very good at all. But we can model the information we have got and estimate what is likely to happen in a large series. Now, what can we do? Can we do a reduction, and how does it work out as far as risks go? The decision of which fetus to select for reduction is dependent on many factors. What if all of them are normal? If they are monochorionic or not? Whether any of them have got a structural abnormality? And even if there is no structural abnormality, is there any way we can select the fetus to reduce? So there are many features to be undertaken. So here is a study which looked at what happens to triplet pregnancies if we reduce versus we don't, to compare the outcomes of expectantly managed trichorionic triplets versus reduced. Now, mind you, this is not a randomized controlled trial. It's impossible to do that. Nobody will be agreed to be randomized to do it. So this is an observational study, and women with trichorionic triplets were considered, and primary outcome measures were miscarriage and early preterm birth. So these are the things that we are looking at. So approximately 230 women, triplet pregnancies were managed expectantly, 265 were reduced from 3 to 2. And their basal characteristics were more or less the same. And this is what happened to their gestational age at birth. So expectantly managed triplets, the median gestational age at birth was 33 weeks and 8 days. And when they were subjected to reduction, there is a shift of gestational age at which they deliver, and the median gestational age at the delivery was 36 weeks and 1 day. So we can significantly gain gestational age by reduction, selective reduction. Now these are the survival curves of expectantly managed and embryo-reduced triplets. And you can see that if you're talking before 24 weeks, there is a significant increase in loss. But a switchover happens between 24 and 32, and then we get a significant gain. So at the cost of increasing early miscarriage, we are gaining in terms of gestational age at birth. So that is what happens with triplet pregnancies with reduction. So as far as survivals are concerned, at least one survivor is seen in approximately the same number of triplets as either with expectant management or with embryo selective reduction. So, armed with this information, we can model what is likely to happen in a large number of triplets. So let's talk about 1,000 triplet pregnancies, either managed with embryo reduction or with expectantly managed. So we know that miscarriage rate is slightly higher if they are reduced. So then we reduce them, we are left with 2,000 theoretically versus 3,000 if we don't reduce them. But some of them will have miscarriages and some of them won't. So those are the numbers that we expect will happen. And at delivery, we can expect what is likely to happen to them. So these are the number of triplets that will be delivered. 90% will reach to delivery versus 93% in expectantly managed triplets. But if we adjust their morbidity rates with the gestational age, this is what is likely to happen to the handicap rate of them. So if we reduce them to triplets, from triplets to twins, we are likely to see 30 handicapped babies as opposed to 106 handicapped babies in conservatively managed triplets. And this information, I think, is useful to be conveyed in terms of when we talk to women about possibility of triplet reduction. So this is a systematic review looking at a large number of triplet pregnancies, and spontaneous miscarriage rate was approximately doubled with embryo reduction. But early preterm delivery was reduced by a factor of 3, 1 in 3. So 3 times reduction in early preterm birth. So how can we summarize all this information? In trichorionic triplets, embryo reduction to twins does not improve chance of survival. The chance of survival remains approximately the same. It significantly increases the gestational age at delivery. We know that. And this may have an impact on handicap rates, although we don't have direct data to show this. The model data shows that it is likely to reduce morbidity rates. When we talk with women who have got triplets, the reaction is mixed, and it all very much depends on what their background is. By and large, pregnancies that have been conceived after fertility treatment, they're very reluctant to undergo any intervention because all they want is a live baby. But this information is useful to, we are obliged to pass this information on to women in order for them to make a decision as to what they want to do. Now, we are increasingly coming across dichorionic triplets, and that is trouble because monochorionic pair has a high chance of developing TTTS, selective IUGR. The reduction of one fetus is technically challenging. And we don't know whether to reduce from 3 to 1 if we reduce the monochorionic pair, or 3 to 2 and leave the monochorionic pair behind. So it's a difficult, really, really difficult decision to make. And this is something that we published a few years ago, dichorionic triplet pregnancies, risk of miscarriage and severe preterm birth with intervention. And these were our numbers. The three-center systematic review, 225 triplets were managed expectantly. These are all mixed chorionicity. Miscarriage rate was about 9%, severe preterm birth 33%, and we know all this. So it's not so very different from trichorionic triplets. If we reduce from 3 to 1, and there were 55 of them, miscarriage rate increases to 15%, but severe prematurity rate is really low, it goes down to 6%. If we reduce from 3 to 2, then miscarriage rate is more or less the same, but severe prematurity rate is somewhere in the middle, 14%. So what can we conclude? We can conclude that embryo reduction to singletons increases the risk of miscarriage to 14% from 9%, but reduces rate of severe preterm delivery from 5% to 33%, from 33% with conservative management. So there's significant improvement in terms of what we can gain in gestational age. Now we must remember that there is significant impact on multifetal reduction on women's psychological health, and many of them continue to think about it for a long time after the event. 1 year after birth, 1/3 of women reported persistent depressive symptoms. So this is something that should not be taken lightly. So in summary, what we can say is that the risk of miscarriage peaks soon after embryo reduction, but remains throughout gestation. Women often ask, if I undergo this treatment, how long am I exposed to the risk? And there's no answer, because the risk persists for a long, long, long time. So each case must be carefully and individually assessed, and careful decision-making, counseling and support is really necessary. We must not forget about ethics, and this is something that was mentioned by the first speaker as well. We have to respect self-determination. It's not our decision. It is the couple who has to decide. We've got to maximize the benefit, not only for the woman, but also for each of the fetuses that we are considering. And then we have to minimize the risks that are associated with it. With this, I hope that I've given you an overview of how to manage triplet pregnancies. Thank you very much.